लॉगिन लिंक भेजा है ना उसने लाइव स्ट्रीम का। Okay, we are 9 o'clock now.
Yeah, I'm here.
Ma'am, people are not able to join through the barcode that has been
मुझे
given.
पता है, मैंने सुबह बशीर को बोला, विजया को बोलो, ऑर्गेनाइज करेगी तुरंत एंड AGRS
मैम मैं
में
आपको
डालेगी।
पूरा फ्लो भी भेजे सोए, रिकॉर्डिंग भेजे
कहाँ
सोए।
भेजे, किसको भेजे?
वीडियो में ग्रुप में डाला मैम, आपको
कौन सा ग्रुप?
AGRS मेंबर के ग्रुप में।
अभी
Ma'am,
डाला है
can I
उसने,
put the
लिंक
Saturday
डाली है।
link?
he's put right now.
अच्छा ठीक है, ओके, तो
अभी
देन
डाला
लेट
है
मी ज्वाइन। ठीक है, पीपल विल ज्वाइन।
Hi, Uma madam. Good
हाय
morning.
इमरान, हाउ वाज योर वेकेशन?
It was amazing.
I'm sure it was.
Did you see the rare bird?
Yeah, we saw the puffin. देखा.
I don't remember the names, so good you reminded me.
Good morning, ma'am.
Good morning.
Arzu,
Sorry, I'm just trying to send this link to few
send
more
you a link,
people.
tell all the JRs to join.
Yes, ma'am. Yes, ma'am.
Good morning, ma'am.
Good
Shraddha
morning, good
here.
morning.
मैम इट्स ऑलरेडी 9 मैम, कैन यू स्टार्ट मैम?
या तुम्हारे लोग ज्वाइन कर पा रहे हैं?
1 मिनट मैम, चेक कर रहा हूँ मैम।
हाँ, चेक करो।
मैम ऑनलाइन में ऑलरेडी 33 मेंबर्स हैं मैम।
ठीक है, श्योर देन लेट्स ज्वाइन, लेट्स स्टार्ट।
मैम रूपाश्री मैम, कैन यू स्टॉप योर स्क्रीन शेयर?
रूपाश्री, म्यूट योरसेल्फ एंड स्टॉप द स्क्रीन शेयर।
Yes, ma'am.
Stop the screen share, please.
Can I stop the share? Okay, just a second.
Hi, Shraddha.
Hello, ma'am.
How
Good
to
morning, ma'am.
stop the
How are
share?
you?
Yeah, good, ma'am.
Good.
Thank you,
Very
ma'am.
nice.
Yeah.
I can see Jyoti is also there. Great. Morning, Jyoti.
So, yeah, good morning, ma'am. Good morning, everyone.
Good morning.
So Imran is in charge today. Imran can start.
Okay, madam, we can start.
Yes.
Chalo.
Let's start with the initial introduction and start with the lectures.
Yeah.
And again, request for everybody. It's Sunday. Let's finish our whatever we are talking in 15 minutes, so that there is some time for the people to send messages. Because
Yes.
I want 5 minutes. I will try and take out from my time only to
Right.
talk about our upcoming RoboGyne India and all the training pathways that we are trying to do it with AGRS. So
Perfect.
go ahead.
Should we start? Wonderful.
Sure. Go ahead.
Hi, good morning, one and all. My name is Dr. Imran Hamzawala. I'm one of the robotic gynec and gynec-onco surgeons from Sefi Hospital in Mumbai. And I welcome everyone to this wonderful webinar, this bright and hot Sunday morning from Mumbai, on robotics basics that every beginner should know. Why is this important? This webinar important because we all started somewhere where we were new to the robot. And every time we try and embrace a new technology, there are certain teething problems that we need to navigate through. And who better to help us navigate through these teething problems than three eminent specialists or stalwarts in robotically assisted surgery in India, Dr. Anshumala Shukla, Dr. Rupashri Dasgupta, and of course, our AGRS president, Dr. Uma Sinha. Why is this webinar so important? Is because anyone who's starting off with their robotic journey will realize that having an understanding of how to go about with it is so critically important. But more importantly, the ones who are already well established in robotic surgery, this webinar is for you as well, because every given time we need to sort of consolidate our fundamentals, and this webinar proves will hope to stimulate the fundamental understanding of how to go about with robotic surgery. So just some housekeeping advice that please, whoever is joining in, keep their mics on mute so that the speakers are not disturbed. A request for all the speakers to keep to time, and we would love to have an engaging panel discussion with our four panelists, which we will talk in due course. So without further ado, I would like to invite Dr. Anshumala Shukla Kulkarni, who is the Secretary General of AGRS and is the head of the Minimally Invasive Division of Gynecology at Kokilabende Rubai Ambani. And she will be talking to us about something incredibly important, which is the technicals and the core setup, in your journey through robotic surgery. So, Dr. Anshumala, please, the floor is yours.
Thank you very much, Imran. I think this is a very pertinent topic that you and Dr. Anupma have picked up as our webinar leaders. Because everyone has to start at basics, and sometimes you have to revisit your basics, and you should know, how it is. So quickly, let me start off with my presentation here. So we are essentially going to be. So you're able to see my screen now? Yeah. Okay.
Yeah.
Yes, we
So
are
we
seeing your
essentially
screen.
looking at robotic surgery as we knew it initially. To start with, I'm going to talk about the Da Vinci platform because that's what I began with. However, there are a lot of new platforms available now across India. By and large, most of them would have the similar mechanics or understanding of placement of ports as well as use of instrumentation. We all know that our robot consists of all of these three things. We are very familiar about it. So we do have a closed console, which is a surgeon's console, on which the surgeon is going to look in a three-dimensional view, and hold masters which hold the instrument. You got the patient cart in the center for the entire OT to view. And then you have the robotic arms, which could either be single standalone stacks or could be like a proper boom with like the XI or the MedBot or the Edge or the Merrill robot would have. So this is essentially what it looks like. We have typical instruments, and what you would generally require to use would be a bipolar, a scissor, and a needle holder. The masters. So it's very important when you sit at the console to understand how to hold it. A lot of people are confused about which fingers to use. I think keeping the index finger free to be able to use the clutch on your finger clutch is very, very important when you're doing your robotic surgery. So you just use your second finger and your thumb to essentially move it. And all of your movement is going to be on your wrist. I always keep telling my fellows that when you're doing robotic surgery, unlike laparoscopy where we're using your elbow to move things, here you're going to be using your wrist. So learn to twist your wrist and make the full use of the 360 degrees of freedom or 7 degrees of freedom or 360-degree angulation that the robotic instruments actually offer you. As I said, this is what we are looking at, and keeping the ergonomics is very important. So here again, making sure that you are sitting straight with your neck at rest, your shoulders at rest, and your back at rest. The robot can actually move towards you. So you do not need to slouch on the console to be able to see. You can actually move it across, and it's also very important to have a very comfortable seat. Something sometimes OR may not think about or even consider when they're starting robotic surgery with you. But it's very, very important that you have this very comfortable seat to sit so your back is supported, because ultimately ergonomics is one of the biggest advantages the surgeon has in doing minimal access surgery with the help of robotic system. This is typically how an OT would look like. You do need a fair amount of space because you have the robot coming in from one place, you have the patient cart, the surgeon's console, operating theater, and the anesthesia trolley. But the setup looks pretty much like this, where the anesthesia trolley is to one side and everything comes there. Generally, the robot in gynecological surgeries will come from the left side of the patient. So that allows only one single arm to come to the right side. The other two arms are on the left side and gives the vaginal space open for vaginal manipulation to be done easily. The docking used to be initially done central docking, but I think now with the boom, that is not a option. The side docking is what we are generally using. Again, here you can see patient is properly in a steep Trendelenburg position, and the instrument and trolley has come from the left side of the patient. Port placement, with the boom that comes in from above, even a linear arrangement of port works very well. Because the instruments are long and there are no clashing of instruments because they are spread out very well like a lotus flower on top of the patient. So there is no question of clashing happening over there. However, in gynecology, I do find that placing your camera slightly above and placing the others in a slightly curvilinear position gives us a little more advantage being able to access laterally deep into the pelvic cavity. So I think a curvilinear approach would be very good, with the assistant port being slightly above the camera port. Now coming to positioning. So this is typically what we would use to have a safe positioning for a patient. So you want Allen stirrup. These are stirrups which are movable. They have support mainly. They don't necessarily cause any pressure at the nerves over here at the knee joint. However, they have good support and the entire weight of the leg is actually coming on the sole of the foot. The hands are always tucked ergonomically inside. So I'll show you a video of this. So this is how typically you want that. You want a stirrups which is going to be able to move your legs up and down in this manner. Now, this is very important when you're trying to extract specimens from the vagina, where you want enough space in the vagina to be available. So these stirrups actually make that happen. And at all points of time, you can see that the hand is very neatly tucked and also given a lot of support. So the next thing that is important is to have very good safe placement of the patient. You need good amount of shoulder supports. You could use an anti-slip mat available as well, which is a gel mat which can actually prevent the slippage of the patient, because you're going to give a steep Trendelenburg. And as it so often, especially in an obese patient, you will find that the patient will start slipping on the table. So you need to be careful about that, mindful about that, and make sure that you're using good amount of shoulder supports if you don't have a non-slip mat. Eyes are covered and the IV lines and everything are secured with great extensions so that you're not interfering with this. So this is how typically we will give our positioning. So the table goes as low as possible. Again, that allows us to make sure that there is a good amount of clearance of the robot arms to move along the patient's abdominal cavity, around the patient's abdomen. So it's very important to make sure that you've got a table which is going as low as possible and be able to give you a good Trendelenburg position. So this is ultimately how you would do. And if you see, all points are secured. So the legs are secured, the knee joint is comfortably placed, the hands are tucked in, they are also supported by Gamgee padding. You have IV lines which have got an extension. You have the the electrocautery secured very well on the thigh, placed very well. You have the eyes are covered and you have shoulder support. So I think all of this is very important to keep the patient safe, because you're not going to be at the patient's end. Unlike laparoscopy, where you sometimes feel the patient is shifting, that does not happen with this in robot, because you're not there at the patient's end. So, making sure the patient is very, very secure is very important. Again, here you can see that we are demonstrating how the table is going really low, and then we start giving the head low. So this is typically how, after painting, dripping, and the ports are in, how the patient is going to look. So you, again, we've done the draping, we've put the ports inside. Now we're going to lower the table down. You can see that the patient's cart is placed here on the left, above the left shoulder of the patient. The assistant port is on this side, on the right side, so it allows them to directly view the screen over here and have access to it. The vaginal end is also accessible because the port is going to get the robot is going to get docked from the left side. So that's typically how we would want to place the patient. And you can see now again a steep Trendelenburg is being given. Now that's the robotic system being docked. So this is our Da Vinci XI docking, which essentially has a boom. The advantage of this boom is it can orient the arms to go either looking to the left, to the right, to the thorax, to the pelvis, without changing much in the arms. So it allows us to be able to orient the robot without changing too much in the patient's positioning. It has a target function. Again, now this is meant to, so we orient the arms for a pelvic surgery. Then we use these crossbars, which allow us to place the main port exactly at the target area there. And you first go ahead and do a docking for the primary port. So when you're doing the docking for the primary port, Again, here, the idea here is to make sure the alignment is that this is a male patient, just an example to show you how the docking is done. So you can see here, we let all the arms be, but we just take. So you can see here, there is the arms that have been placed are actually in a straight line, a linear fashion, which works very well for patients actually. So you can see that there's an assistant port. They are using an air seal. So there's an air seal port there and an assistant port and 4 arms of the robot. So now that the main camera arm or the arm 3 has been docked, we are going to now push the camera inside and use the docking function, the target function of the robot. How that helps is it allows both arms to remain away from each other and places the robotic arms lower as well, so that there is good. So you can see here that once you do the targeting motion, the arm is actually come down and the arms move away from each other. Post which then we go back to docking all the arms. The arms in the Da Vinci are fairly easy to dock now. And once you've done this, you are able to move the trocar up and down as much as can. It's very important to always place your instruments under vision. So once you put the instruments in, you must always place your instruments inside the abdominal cavity under vision. So when you're putting it, you first basically decide which instruments you need to take. So that's something that I will just show you shortly. So you can see here, all the arms are going to be pushed in when they're totally under vision. You see these black and yellow lines on the side. They are guides to tell you where your instrument is actually coming in from. And visualizing the path is very important in order to avoid any inadvertent injury to the patient. So basically that's the Da Vinci X being docked, which is always from the left side. So this is not the SI, this is the X. Here there is no boom. It's just a cart which comes in here. Very important to make sure that the first arm that you're doing is spread out as much as you can. All the shoulders and the elbow of the arm should be spread out so that there is good and free movement. Generally, you want to place your hands between the port and make sure there is enough space, at least 8 centimeters of space between the ports, to be able to prevent any kind of clash. Usually, if you have not spread your arm out correctly, the elbow of the robotic arm can actually clash against the camera and make it difficult and obstruction. So this here ideally will be pushed outwards so that there is enough space between the arms to allow the docking to occur. So that's, again, like I said, ergonomics is very important. So being able to move the camera, move the Da Vinci exactly where it is placed. So you can see here, we've moved it down. My shoulder is straight. I'm sitting comfortably and I don't bend. So here I don't want to bend my arm. So I lift it up so that my neck is also not bent. And I'm actually in a very comfortable, neutral position while I'm doing the surgery. Also, when I'm doing the surgery, the hands have to always remain in the center. So I'm holding the masters, and with those clutches, I will ensure that my hands always remain in the center, in that little rectangle that is there behind. That ensures that you are not allowing your instruments to go out of vision or allowing things. Now, the instruments that are used, typically my instrument trolley looks like this. I use 3 ports for most of my benign gynecology. If at all have to add something, I would use a Progress. But it's essentially a bipolar forceps, a large needle driver, and a monopolar curved scissor that is used here. So the instrument trolleys are placed in this way with the nurse. And so that's basically the assistant, of course, is very, very important to be able to do suction, irrigation, and go on with doing the surgery. So I think I can stop because my topic here essentially was to show you port placements and how the OR should look like. And I'll be happy to take any questions.
Thank you, Anshamala. That was an incredibly wonderfully clear breakdown of the technical foundations. Knowing how to set up correctly, because when you set things up correctly, half of the battle is won in robotic surgery. So, in the interest of time, I think we'll move on to the next speaker, because we want to have enough time for problems and solutions during robotic surgery, the panel discussion. So without further ado, and if the audience has any questions, you can start posting them in the chat. So we will entertain those questions, during the panel discussion session. So without further ado, I'd like to invite Dr. Rupashri Dasgupta. She's a very senior gynecologist, gynec-onco surgeon at Apollo in Kolkata. and she will be telling us as to which patients are likely to benefit from the robotic surgical technology. So, Dr. Rupashri Dasgupta, please, over to you. Dr. Rupashri?
Rupashri, you're muted.
Can you hear me now?
Yeah,
Yeah.
and can you also put on your video if possible?
It's not working for some reason, ma'am. I have to look into the camera, look into this problem later on. A good morning to everybody, and let's move on from Dr. Anshumala and talk about the clinical indications. So when we talk about the advantages of the agenda for today's talk would be, first I'll talk about the advantages of robotic. What are the indications with evidence in both benign and onco, with a bit of clinical scenarios and videos if possible, if we have time, and a few take home messages. When we look at surgical approaches in gynecology, there are many of these approaches which are available, and robotic is one such approach. And today we will discuss what are the indications and what are its advantages compared to basically laparoscopy and open. Now it's a breakthrough technology. This is not going to, it's not a replacement for laparoscopy. It aims to overcome the shortcomings by overcoming the surgeon shortcomings and the equipment limitation, and the end result, we end up with less morbidity, faster recovery, and greater surgical precision. This was a study done by our president, Dr. Uma Sinha et al., and it shows that how the uptake of robotic has changed over the scenario over the last 10 years, and more cases is being performed on different kind of platforms. Today again I'm going to speak on the Da Vinci Xi because that is what I work on. And as every study later on, you will see that say that the robotic OT console time is longer than lap. But if you look at this study, if you see that the number of years and with the experience of the performer or the surgeon, the console time will gradually come down. Now this is just an overview of the robotic in our hospital. It's an Xi, it's a Da Vinci. You have the boom. The reason I'm showing this is because in when we do a multi-quadrant surgery and we're looking upwards, the boom just rotates around, and then it becomes very easy for us to actually perform both the surgeries without having to dock and redock 10 times. These are the small movements that you make with the hand, and now it gives us an immersive view through a 3D high definition visualization. You feel as if you're inside the abdomen when you're operating. The camera is under the surgeon's control, and so minimal use of the assistance, and it's a very steady camera. You can move it wherever you want to. Wristed instruments, improved ergonomics, and that helps us with better suturing and dissection in confined spaces. Now, when I was talking about the wristed movements, this is the endo wrist movement, which I've tried to make this video to show the beginners who are watching today, to see that how the movements of the robot or the wristed endo wrist, it actually follows the way that we do open surgery with a 360 degree rotation. Now, the other advantage of the robotic is we have something called the Firefly technology, wherein when you inject ICG dye to inside the ureter, or you want to look at endometriotic lesions, ovarian cancer spread, sentinel nodes, isthmosil repair, anything, you inject the dye, and this camera emits a near infrared light which picks up, and this glows green, and that helps us in preserving many organ functions. Now, this is another chart which shows the comparison between open laparoscopy and robotic. Recovery is very swift. Laparoscopy and robotic, there is not much difference, but as I take you through the indications, we will see what are the advantages. Now, port placement, as I said, in benign cases, you don't have to go for a straight line. In some cases, when you're doing the upper abdomen and you're doing a multi-quadrant surgery, this is generally how I put the port. That time I go straight because I need to work both downwards and upwards. You just turn the boom around, and the camera port is the extra port that we take. The rest port remains the same. Now, these are the post marking. That is the area of no entry, and we should not put any instruments down below. This is how it looks when I use the third arm. I generally take the assistant on the opposite side. So we have assistants from both directions. I don't know, for some reason I started with right side docking, and that is how comfortable I am with that. Now in a benign gynecology, let's take benign first and then we go with onco. Now we do a hysterectomy for benign disease. Robotics can be done for every single case, and I feel that it gives us a better control over the surgery in every single case, but it is especially useful in large fibroid uterus where the anatomy is distorted with a broad ligament or a cervical fibroid, in severe endometriosis, dense pelvic adhesions, obesity, high BMI, narrow pelvis, and complex pelvic reconstructive procedures. Now, if you look at the evidence, then Dr. Edwin Kula et al. Has done this study, and which has compared the laparoscopy and robotic surgeries. Conversion to laparotomy is significantly lower with the robotic in case of difficult cases, and there is no difference in complication rates in both the procedures. Now, what happens in a difficult large uterus? You cannot see the pelvis properly, but the manipulation of the large uterus is made easy by using the robotic platform. We are going to go very fast with all the videos here, and the dissection is much easier for the bladder even when you have any previous surgeries, so injury chance is less. Better visualization with the 3D magnification, easier to safeguard the ureter. So when you open the lateral peritoneum, it's very easy to open the lateral peritoneum on the robotic platform. You can see that this is the ureter here with the arrow here with my marking, and then you can clamp and cut the IP ligament. Next, when you are having a better uterine artery control, you can see that this is the ureter coursing at the side, and we are well away from the ureter. So this is an advantage. Another advantage here, when you see with a broad ligament fibroid, we know we are worried about the ureter on the lateral side. And so here in this case, we can use the ICG dye because the MRI had said that it was sitting right on the ureter right there. So you remove the fibroid first from the ureter and keep dissecting. And finally, you can see that you've pushed it well away and you've protected the ureter. Yeah, you can see the glow there. Now, coming to myomectomy. In myomectomy, what are the advantages that we have on the robotic platform? And just a second, I just missed out my screen. Yeah. So when we have multiple fibroids, deep fibroids, when we are doing a fertility preserving surgery, which requires multi-layer suturing, and we have abnormally located fibroids, and even in adenomyomectomy, robotic gives us a better control and helps us to, why is my screen not moving now? Sorry, my screen is not moving. Just a second. Am I audible? Am I audible?
Yes, you're audible,
Yes, you're
Dr.
audible.
Rupashi. Yeah.
Yeah. So now if you look at the evidence for myomectomy using the robotic pathway, so this was a systematic review and a meta-analysis which shows that apart from the operative time, the blood transfusion, the hospital stay, the intra blood loss is all better with the robotic platform. The conversion to open is also lesser on the robotic platform. Post-op complications are again lesser. This is another very interesting study wherein they have compared the laparoscopic myomectomy to conventional myomectomy in cases where we are trying to preserve the uterus for future fertility, and they saw that doing an ultrasound at 1, 3, and 6 months, the hematoma chances are much lesser in a robotic. It means that the healing is better when the patient is trying to conceive. This is another study by Dr. Ruma Sinha et al., wherein they have done an extensive 10-year observational study which shows that there is a very good healing rate and pregnancy rate after robotic myomectomy, which is 86.4%, and they never had a uterine rupture in the 10 years. Now, this is one of the difficult myomectomies that we have done in our surgeries in our hospital, where you can see that this is a large cervical fibroid. And first, initially, we would think that it is quite difficult to attempt this on the laparoscopic platform, but in the robotic platform, you can see that this is like a lantern sitting on the cervical fibroid, the dome on St. Paul's Cathedral. And when we assess it adequately, we have already stented the ureter in this case initially. So we open the UV fold first. Robotic helps us to go deep down into the pelvis and further dissection to remove the bladder downwards. prevents bladder injury. Lateral side, we are opening here till we find the IP ligament. I'm still searching for the ureter. Here I find the ureter coursing right through the fibroid. Now we've identified the uterine vessels, coagulated and clamped them. And then further dissection is done to remove this giant fibroid, and it's a successful surgery. We've preserved the cervix, the uterus, and we've managed to remove it. Now, another important advantage of is the multi-layer suturing, which is easily done on a robotic platform. This is a submucous fibroid, but a patient had completed her family. She had such a large submucous fibroid that it was difficult for us to remove it hysteroscopically. I had given her GnRH. Even after 3 months, it was refusing to shrink. But on the robotic platform, we were able to do this with ease. And following that, the multi-layer suturing, which is done here, where we have not included the endometrium goes in, and it is done with ease on the robotic platform. It's quite precise, very neat, hardly any blood loss. This is the first layer. Now this is the second layer. I'll just take through very fast because of the time, and this is the third layer. So going from myomectomy, we will now go to endometriosis. I think the robot was built for this kind of surgery, whether it is endometriotic cystectomy or a DIE or a bowel disease, ureteric endometriosis, bladder endometriosis, complex adhesiolysis, or we are doing a fertility sparing endometriotic cyst surgery. Evidence shows that a robotic surgery facilitates meticulous dissection in distorted anatomy and helps in organ preservation. Let's go with the ovarian cystectomy, where we need a fertility preservation. What is the advantage and the indication? So this study has shown that when you compare robotic with laparoscopic surgery, the percentage of AMH detection after robotic surgery is much lesser than that of a laparoscopic surgery, with a significant p-value. This is our own Ruma ma'am study, where she has also demonstrated that when you are doing a robotic surgery, actually we are not yanking on the pedicle, we are not yanking on the cyst, we are actually doing a micro dissection. And after that, when the cyst was compared using artificial intelligence whole slide imaging, they found that the area of ovarian loss was much higher in a laparoscopy rather than in a endometriotic surgery. We are not pulling, we are just doing micro dissection, and we are just dissecting and preserving the ovarian function. Now, when we go to a difficult surgery, like an ureteric endometriosis, where there is so much of adhesions, in this case, you see that the anatomy is distorted, the ureter is completely adherent to the parametrial nodule there, endometriotic nodule. So here we can again do the micro dissection. It's preventing the ureteric injury also because of precise ureterolysis. In difficult cases where you need nerve preservation, you can identify the nerves and preserve them also. And once the ureter is dissected off, we go in for the butterfly peritoneotomy. You can use the ICG dye here. We have used it in the intravascular injection to see the vascularity to the ureter is preserved or not. And then we complete the rest of the butterfly peritoneotomy and shaving off from the endometrium. So this is the way in which we use it in endometriosis. You can use ICG dye also to pick up the endometriotic lesions and also to see if the bowel anastomosis is proper or not. So the entire butterfly peritoneotomy is done. This is how it looks at the end. Now, this is another good video wherein you see that when we are not able to approach a very difficult vaginal nodule there, a laparoscopy instrument may not be able to reach that deep, and your assistance also would be difficult for her to reach that deep to assist you. Robotic will give you that platform to reach there down very easily and help to remove that nodule. Coming to the next indication in benign gynae, that is pelvic organ prolapse, sacrocolpopexy and pectopexy. What does the evidence tell us? There are two meta-analyses here I'm giving you side by side. Jiang et al., they included 3,000 patients and showed that there was a similar anatomical and functional correction rates between robotic and laparoscopy, but always the conversion to from lap to open was higher than the conversion from robotic to open. So, and also in this other study, they showed that it is very much useful in complex. It's a meta-analysis, and the meta-analysis, if you look down below, that you see that the functionality is the same, but it is much more useful in complex or technically demanding cases, especially cases where you need to do a resurgery or a redo prolapse surgery, or in complex cases where there is a lot of adhesions. So here again, because of the robotic instruments and superior dexterity, you are able to get a good vaginal cuff. You should be able to dissect the bladder completely off with a long length if you have a cystocele actually, and posteriorly also we need to dissect based on how deep is the defect. If there is a rectocele, then we need to go right up to the levator ani and the perineal body. Now coming upwards, here we are opening, here you can see that how the robotic one arm is helping to keep the bowel away, and you are dissecting with ease to open up the tunnel and the sacral promontory. There is hardly any blood loss, and these surgeries are done with ease. So once you have created the tunnel, now you've taken the mesh, and the mesh suturing is especially easy in these kind of cases. Here I've taken a macroporous polypropylene mesh, and I use non-absorbable V-lock sutures. You can use interrupted or continuous. Look at the posterior suturing made easy here. This is what I wanted to demonstrate. And once the mesh fixation is done, it is fixed actually very stably in a robotic platform. And then after that, you can take the Y and then look at the suture here. This suturing is also made very easy on the robotic platform with this Proline, where I take 2 or 3 bites on the sacral promontory. It's so easy to dissect and stay away from the ureter on the right side and the median sacral artery on the left. Once you take these knots, and it's easy to just take this thread through the wire, and very stable and full control. So these surgeries are done very much easily on the robotic platform. Once the whole thing is over, you reperitonealize the tissue. And when cost is a factor, so in benign gynae, when cost is a factor, we don't need to use the third arm always. We can use the needle driver to do lots of your dissection. In this case, it is dissecting on the left side. On the right side, you will see it's a large uterus, and the arm itself is helping us to give the traction and lift up the pedicles.
Dr. Rupashri, 2 minutes, please.
Yes. Okay. So role of robotics in onco. If you look at CA endometrium, CA cervix, and CA ovary, strongest evidence is for hysterectomy, central lymph nodes, pelvic and paraortic nodal assessment, and omentectomy for high-grade histology. In cancer cervix, we know after the LAC trial, we are not doing a lot of robotic. We are waiting for the RAC trial. And we recently saw that the analysis of the RAC trial in the surgeons meeting, that the sentinel node uptake is very high in a robotic platform. Robotics still has a role in fertility sparing surgery in radical trachelectomy. In CA ovary, the role is limited, but we can do it in early stage cancers, in interval debulking surgery after the mirrors trial, and secondary cytoreduction in selected cases where there is not much disease left in the pelvis or the abdomen. Now, this is a very important study which shows that in CA endometrium, we know that the patients some are obese and morbidly obese, and this analysis shows that especially in cases of BMI more than 30 and 40, the conversion rate is much lesser in robotic, and also it is gives a greater benefit in technically challenging patients where we have to give a Trendelenburg or the exposure. In these cases is where the robotic comes into play. Now, in this meta-analysis also, it shows that when they compared robotic to laparoscopic in endometrial cancer, the conversion to open was much lesser, but in robotic platform, but there was no difference in overall survival or disease-free survival. Now, in vulva, we use it for doing the veil surgery for very early cancer when the tumor is less than 4 centimeter, and the groin study has shown that there is a decreased wound background infection and lymphoceles with that. And in radical other pelvic surgeries, we use it for pelvic exentration. It is increasingly being explored, but we still need to have better studies to demonstrate that. This is just a small demonstration of how we are using the orogreen. We are first injecting it superficially and deep after diluting the ICG dye. This is the port placement, and then once we are inside, you see which is the sentinel node. You take care of where the sentinel node is. Have a look where it is. By putting on the Firefly technology, it will pick up the color, and then we can actually remove the node. So because we're running short of time, I don't have much time to show you this. So this is how we do a sentinel node. This is how we do an bag. We put the whole thing in early ovarian cancer. When we are worried about spillage and oncological outcomes, we never aspirate the cyst. We remove the cyst intact, put it in the bag, close the bag, and take it out from below. This is another case wherein we are doing an omentectomy, where it really helps. It is a game changer in omentectomy because the exposure is so important. The way that you dissect is so important. You're going to work in narrow spaces near the spleen. You can come in with the vessel sealer, and the robotic helps us to complete the surgery in a quicker and faster fashion. So the vessel sealer again helps in reducing blood loss. When you go to the pelvic nodes again, it helps in meticulous dissection. And in the para-aortic lymphadenectomy also, the robotic gives us a good platform for us to actually dissect all the nodes faster and complete clearance. There are few studies which have shown that the nodal yield is higher on a robotic platform than on a laparoscopy platform, but they are not very statistically significant. So we can reach right up to the renal vein here. That's the renal vein over here. And you can do this dissection very clearly. So this is the evidence summary, wherein if you see that there is a very strong indication level 1 evidence for endometrial cancer, benign hysterectomy, all is level 2. We need much more larger studies. So the conclusion would be that in a surgery, always think one step ahead. We have to place the instruments in a robotic surgery. Stably, we have to put the exposure before dissection. Economy of movement, very important, and the coordinated movement ends in surgical choreography. Now coming back first to my first slide again, that when a patient comes to us with so much of hope, we are thinking about the success rate, what is the good chance that we can give. We have to tailor the surgery according to the patient's desires and our surgical expertise, and for that particular situation, which is important, and we have to take all these things and not only jump that we will do robotic for her or laparoscopy for her. Discuss it, take an informed shared decision making, and then decide which is the best for the patient. And we are all members of AGRS. Ma'am is our president. This is the website. Please click onto this website, agrs-india.com, and it will take you straight to the membership portal. You can take a 1-year or 5-year membership if you are don't have a robotic certificate yet, but if you are certified, you can become a life member. Thank you one and all.
Thank you, Dr. Rupashri. Sorry, I just want to confirm, am I audible?
Yes.
Yeah. So thank you, Dr. Rupashri. It was a vast topic that you tried to consolidate, give us a comprehensive overview of the entire clinical landscape. So we really appreciate your input on that, and I'm sure the audience has got a gist of how we can expand the indications of robotic surgery. We've heard about how to have a technical setup from Dr. Anjumala. We've heard about the indications, and now the million-dollar question is, how do we get trained in robotic surgery, and how do we create a training roadmap for us? And who better than Dr. Uma Sinha, our president of the AGRS, and a teacher and a mentor par excellence, to take us through the training pathways. So without further ado, I'd invite Dr. Uma Sinha to guide us as to the training pathway. Thank you so much, madam.
Thanks, Imran, for taking this forward. And I'm really, really thankful to you and Anupma to bring this webinar together. And I hope that every month or every second month, we should have one webinar where we can actually talk to our members, maybe get more members, and help them in their robotic journey. So I will just start my screen share about talking about how do we do training and credentialing in robotic surgery. To all the people who have logged in here, I know some of you are already trained surgeons, so you know what you have done, and there's always room for improvement. For all of you there who are at the beginning, I'll take you through why we need training and credentialing in gynecological robotic surgery, because that is a little different from what we have been doing. So I bring you greetings from Hyderabad, Apollo, and all of you are welcome to come here to my center to any time, or to go any of those proctors and centers that AGRS is actually trying to endorse, where you can learn your training. So today my talk will be basically on 4 aspects. Number 1, what is a learning curve? How do we get certified? How do you build a team? And how do you ultimately translate it to a cost-effective way of treating your patients? We also have a YouTube channel by AGRS. You could subscribe to that. Maybe this program is also going live on YouTube. If you are not able to do anything, or any of your friends are not able to log in, you can actually see this webinar on the YouTube as well. Question number 1, why do we need training? We need training because although we have gynecological training, this is a new technology. Today, we have more than one platform in India, so training might vary. The concept is absolutely new and alien. You are away from the patient, which we have never been, either when we do open surgery or laparoscopy. We are working with 2 energy sources, which we hardly ever do, either in open or laparoscopy. We use only one. Here, right hand, left hand has 2 energy sources. We have computer enhanced movements, which translates into two things, which I feel as a surgeon helps me. Number one is tremor filtration, and the number two is motion scaling. And of course, you need to handle this equipment or technology with technical errors, fault management. How do you do all that? Either you build a team or learn yourself. So the game of training credentialing is to make you a safe surgeon so that you can perform a safe surgery, which ultimately that's what we have signed up as surgeons. So what needs to be learned? Now, we know domain knowledge. Domain knowledge is how to perform a surgery. Most gynecologists trained will know how to perform a surgery, whether it is laparoscopic hysterectomy, myomectomy, endometriosis, urogynecology, or whatever it is. But today, with robotic, you need to know the technical knowledge, which should be practical based. In this training curriculum of technical knowledge, you need to know what is your cognitive skill, psychomotor skill. How do you handle your foot, mind, everything together, and learn in online surgical steps. Practice the console on VR simulations. Attend dry lab and wet lab to hone your skills to master the console. As a surgeon, let me tell you this. Mastering this console is your biggest asset because patient side management, docking, technical fault management, you can always develop a team who will help you. But console, you are in charge, and that's why you need to know everything. So today, looking at it, who needs this training? We, of course, surgeon needs, but we also need to train our surgical assistants, the nurses who are there in the OT, and some technician. For example, for technician, I'll mean somebody who will probably roll in your robot to the right position. So if you're trained, it takes 30 seconds to roll in. Otherwise, you will be going right, left, this line not coming here, that wastes your time. So circulating staff also is very important. We need to train three types of surgeons. One are residents and fellows. And it is good that many medical colleges or where DNB programs are going on, we have robots now. So make sure you use this opportunity, not just learning obstetrics, but be in the robotic OT if it is there in your hospital to run as resident and fellows. What is robotic? At least come up to the patient management, patient side management. Second is we already have MIS surgeons who have various levels of experience and training, and I'm going to come that in a minute. And then they need to move from laparoscopy to robotic. Their training is slightly different. Last but not the least are some surgeons who have probably very low or very minimal laparoscopic experience, are very good open surgeons, but now want to move to minimal access by the use of robotic platform. We need to address these three groups of surgeons in a little different manner. So when we talk about learning curve, what exactly is learning curve? Now, defining learning curve is very difficult and very challenging because there is not one factor in which I'll say, okay, learning curve is so and so many cases. It is not dependent upon how many cases you perform. It also gets influenced by your prior experience of how many open surgeries you have done, what is your advanced laparoscopy training, how well you know your pelvic anatomy, what are your suturing skills, and what is the type of surgery you want to do. Some of us do simple surgery, some of us do very complex surgery. So learning curve in a grade 4 endometriosis may be much higher than doing a simple hysterectomy. So we cannot really say, okay, do 10 cases and your learning curve is over. So it's a little dynamic process here. How do we progress to that? We need to look into 4 domains. Number 1, operative efficiency. So in your learning curve, these matter. How is your docking time? What is your console time? What is your total operative time? And what is your blood loss? During surgery, these 4 things matter to move your learning curve faster. Second is technical proficiency. How good you move. Now, when my fellows work, the first thing I'll say, you're doing with your left hand bipolar coagulation. What's your right hand doing? Do something with the right hand. So economy of motion with both the hands will give you extra 30 seconds, 20 seconds at every step, and that's how you'll become more economical. Instrument collisions. Learn how, when the instruments come very close, learn how to put your clutch, get the instruments away, or make sure instruments are always in view. Camera control, very important. Suturing quality. How many times does the needle fall off? Does it break? Do you get the right angle the minute you hold the needle? These are some things which you need to learn, and these can actually, we have global evaluation assessment robotic skill scoring. We are trying to introduce this in AGRS also. Let me work on this, and very soon we will have this as well. Third, you need to look into your clinical outcomes. What complication rates did you need to convert, length of stay, and of course, is there any readmission? Nobody needs to monitor you. You need to monitor yourself. Do audit every 6 months, whatever cases you have done. Don't tell anybody else if you don't want to, but yourself, you look into your own data and see what better you can do. Last is procedural independence. Now, how many cases do you still need some mentor intervention? How can you manage an unexpected finding? Now, you were inside and you can't locate the ureter. Do you need somebody to come in or can you manage? Intraoperative decision making. Now, there is a bowel adhesion. Can you manage yourself? Do you think you did not counsel the patient, so you should not touch that bowel? So all those things you need to actually start working from the time you think you are going to do the surgery to performance of surgery. So everything doesn't happen the minute you sit in the console. Sitting on console is the easiest part. The most difficult part is how you prepare yourself and prepare the patient, which is what you should look at. So I will propose 4 phases of learning curve. Number 1 phase, if this is especially for people who are beginning, 10 to 10 cases, you just familiarize, be in the OT. See how docking is taking place, how the surgeon is doing instrument control, what is the basic dissection steps, how do you do simple procedure. This will also get added if you do VR simulation program and make sure you have adequate hours in there. Phase 2, procedural competence. Now 10 to 30 cases it will require, where you first of all start with simple hysterectomy, manage bladder adhesions, some bowel adhesions, some omental adhesions, and perform vaginal cuff closure independently. That will be phase 2. Phase 3 is now you're improving your efficiency. Try to reduce your operative time, improve your economy of motion, as I said, and require fewer mentor interventions so that you are able to complete your surgery yourself. And then comes mastery, where now you can handle larger uteri, do a complex myomectomy, do endometriosis surgery, and also now able to teach and mentor others. Reaching phase 4, especially if you think you are capable of teaching, you have actually achieved the mastery there. There are various papers talking about systematic review, about learning curves. Actually, all of them talk about that it's not just one. That means we all think, oh, we did 50 cases or 30 cases or 20 cases and we have gone learning curve, but doesn't work that way. So proficiency, learning phase, competency, proficiency, mastery takes a long time, but it is not difficult if it goes systematically. Second phase now comes. You have understood what to do. How do you get certified? Now, we at AGRS are doing great work to be able to do your certification. So if you look at present in India, the best chance of you is to actually get an AGRS Surg 3-level training. Now, why I want to talk about it? Number 1, it's a very structured program. Number 2, you get a certification from an Indian association associated with a European association. When you get this certification, it will hold in the court of law, because we will give them exactly how we are training, how strict we are in your, in fact, level 1 training at the moment is going on in Bangalore this weekend. So I actually wish good luck to all the trainees. Their exam must be going on right now. Dr. Sashi is taking that. So believe me, some of you don't pass in the first go and we want you to come, because we want to know that you have learned to handle the console well. Once you do level 1, we go to level 2, which many of you are doing, includes observation, online modules, as well as wet lab. And then you have other ways of learning. You have Verticuity Fellowship 1 year. You have Intuitive Fellowship for 1 to 2 years. You have Equivalent Certificate for Intuitive. Now we are from September onwards starting our training programs in AirCard as well. So there is a wet lab training program, simulation, that is level 1 and level 2 training programs on 11th and 12th of September in AirCard. Please text or call Vijaya. This is the number. Please record. Tell her your interest and she will make a list and get you a slot in that. We will also have an AGRS cadaver program at AirCard in Indore in 2026 November. So please, whoever is interested, please put in your name and your number to Vijaya, our secretary, so that she can put you in the list and we will come back to you depending upon the slots. Third, you could also do an ORC program, which we are doing in complex benign gynecology in Belgium. It's a bit expensive because from European standard, but again, a standardized way of teaching for 3 days where you can actually register and come. In case you want to do this program, please get in touch with me because I am the faculty there and I can actually put you in one of the programs there. Then you have many unstructured certification by consultants and hospitals. You are free to attend because every program you attend, you gain something. Only thing is, those certificates actually are very unstructured. They don't hold anything in the court of law. You could have them for your benefit and learn from those proctors as well. What I actually want to bring to you to notice is the Asian Society, that is the ASGRS, is actually doing an agro program across Asia, which is called Asian Gynae Robotic Observation Programs. We have already just done one in Malaysia last weekend. I was there along with. So what we are trying to do is trying to do them with one conference, so that you attend the agro program and then get to attend the conference as well. So we have done in AGRS agro program in Amras last weekend, which we had 6 registered participants who did that program, which included live workshop, a master class, and then the ability to attend that conference. We are doing 2 weeks later at ASGRS agro program with the Taiwan Society, where the annual ASGRS meeting is taking place. This program is already full. We have enough number of candidates there, so little late to join there. But all of you have an advantage to join this ASGRS agro program in India along with our RoboGynae India in August. So this, you go into the website. If you have any difficulty, you call Michelle, which is our ASGRS secretariat. This is her Singapore number. Please call on her and see if you can register. This course registration will happen straight away at the ASGRS website, and it will give you a discounted registration to attend our RoboGynae India as well. So we have 6 centers across India. You can choose any of them for observation. Come back to Bangalore for a master class on Friday. Saturday, Sunday, you get to attend the program of RoboGynae India. So this is an excellent program. We will have Asian faculty also taking classes here, Indian faculty as well. So this is a great opportunity for most of you in India to attend this international observation program right here in India. Second is, when should a credentialing be done? Now, you have learned, you go to the hospital and say, okay, I have learned robotic surgery, put me in credentialing. This is a very individual decision by the hospital. Some hospitals say, okay, you got the consult training, you start operating. Some say you should have 5 cases proctorship. Some say you should have 20 cases. So I think I will not go into it. It depends upon which hospital you are working, which system you are working, and then go ahead and get the credentialing done. However, I still feel there should be some ongoing privileges and accreditation. Again, I'm working on this along with the British Robotics Association to see, because they have a standardized way, because NHS is very strict. They have a standardized way of that every 3 years you need to have a re-accreditation. So through the association, I know government and the hospitals, they all work individually, but association needs to take a lead. So I'm planning to take a lead on this in the next 6 months. I'll come back to all of you of how we will do this accreditation process. So anybody who has done, say, 3 years of robotic surgery can apply. We have certain criteria. You fill those criteria. We accredit you for the next 3 years or 5 years. So we are just going to work on that. I've just had a preliminary talk with them, but this is on the pipeline again. Then team building. So team building is like planning and being a leadership. So role can be quite challenging because you are the surgeon, you have to operate. Hard work and motivating your colleagues becomes the challenge. So before this, let me take you a few points. Number 1, feel comfortable in advocating robotic surgery to your patients. We have difficulty because we have cost factor, we have not limited availability of robot and so on. But if you feel that this is the case right for me, even if you are a good laparoscopic surgeon, but you feel, okay, this is the right case I should do with lap, please feel free to advocate and sincerely, honestly advocate it. We will have administrators, surgeons must define the reason for this program. So if you are going to start a program in your hospital, don't just do it because of a marketing tool. Okay, we have a robot. I'm doing most cases laparoscopically, but okay, we are a robotic surgeon. Please don't. I think we should be honest and justified in doing cases enough to be robotic surgeons. Main goal is to facilitate endoscopic procedures. By this, I mean, if you feel this case is difficult for me, that I should do an open surgery, please feel free to convert it into minimal access by using robot. So these are the things initially which will help you. As I said, it's an alien concept. You are away from the patient. So teach a good assistant and your OR staff to handle patient at the patient level so that you are stress-free working on your console. Please put intellectual process. Audit your work, publish it. Because knowing your information, The second generation doctors will actually get more confident that, okay, we had these senior surgeons, they have this result, why don't I also do? Regular interest group, surgeon staff training in your own hospital, you can organize or meet on these platforms that we are doing. And of course, do outreach community for that. Stepwise implementation, background understanding and training of the surgeon. You are the leader on the surgical robot with realistic aims. Creating a safe OR, ensuring everybody has correct skills and the OR team is ready. The ideal team, you need to have one surgical assistant. I would suggest a doctor is a better person. If you have a colleague, make that person your surgical assistant. At least have 2 scrub nurses, because if one is absent, the other can work in. One anesthesia consultant who understands your requirement of robotic surgery, and 2 theater technicians who are dedicated, that they don't go to laparoscopy or to cardiac surgery or the other day. They are in the robotic, because then they know if there is a fault, how to handle, if the robot has to move, how to do, what is the draping going on. If one is absent, the other can take place. So competent and dynamic theater team will help you successfully implement the gynec robotic surgery, which will be safe and high quality patient care. Docking needs a robust team. There's a sweet spot in docking, as I call it, 8 minutes. You can make it 3 also. For me, let me give you an background. I started in 2012. It took me 5 years to reach the sweet spot. Why? Because at that time, there was no team. Nobody understood what was doing. Every time I was doing a case, a technician would fly from Chennai, come to Hyderabad, help me with docking, go back, and I would do 2 cases in a month, because that was the problem. Today, most centers have very good team. You just need to work with them so that your docking time decreases. 4 to 5 cases a month should be enough for you to develop this. So for us, we actually hired a technician or a dedicated robotic person in 2016 after starting from 2012. And then our docking time and average time became very, very significantly low. This is something I show. This is a very old photo. This is 2012. You can see, of course, I'm looking a little younger. This is my colleague, Dr. Rupa. This is Dr. Shekhar. These were the 3 people we started robotic surgery team in 2012. If you look at today, we are still the 3 people here. The team has increased, a lot of fellows and everybody joined, but these 3 remained constant over for almost 15, 16 years. So keeping the same people, of course, you have to understand how you can keep the same team together is what will work together. We also have other training programs in our hospital going on, which are small console gynecological series. If anybody is interested, get in touch with me. The last is how to make it economical. Now, the elephant in the room is cost. Most people are shying away from doing robotic because it is cost. I don't deny it, it is expensive. What is the strategy? Basically, we need to avoid redundancy of using multiple instruments and consciously reduce the cost per case with corrective surgical preoperative planning. If you have a reproducible technique, your OT time will reduce. For example, this is a simple publication that we did, just using 2 instruments at one time. That means 3 instruments. That is 1 bipolar, 1 scissor, and 1 needle holder to do a hysterectomy with just 2 arms, which we talk about doing everything at one go, then go to the other side. It's an economical way. And if you follow the same thing, teach your team also that this is what you're going to do, they'll know exactly what time to give you what instruments, and you can consciously reduce the time. Cost in robot is fixed cost and disposable cost. Indirect costs are also which are modifiable. Length of surgery, length of hospital stay, and return. So economy will depend upon few things. Now, you can't really compare what I do at Apollo, at what Imran does at Saifi, or what somebody is doing in AIMS, Anupma is doing in AIMS, because hospital cost varies, number one. So a teaching institute, a trust hospital, a corporate hospital, number one, the cost will vary. Then, are you working on a package or are we working on a regular billing? See, these are realities of life. We have to understand. If you work on a package, then it doesn't matter whether you take 3 hours or 5 hours. But if you're working on regular billing, the 3 to 5 hours will, increase your OT time, double time. So that is another thing. Type of platform being used. Now, we have multiple platforms. You have to understand the one that we are mostly using, DaVinci, is the most expensive. But if you look at the newer ones that are coming up, their instrument cost is less, their overall cost of the equipment is less, the hospital is charging less cost. So you have to again see how you can modify your cost depending upon what platform you're using. Number of instruments is in your control. I have learned how to use just 3 instruments and finish most of my patients. We can use a 4th one. So for example, I'll tell you, if I need to put a 4th arm for some retraction, I don't use a prograsp in my hysterectomy. I use the needle holder. So I can still retract, but I have not used a new instrument. I've used the 4th arm. So try to see in your own setup, what is your requirement during surgery, how you can reduce the number of instruments. And of course, whatever platform you used, again in India, it's variable because some hospitals buy the platform, some use for pay for use. The cost varies. If the hospital buys, then you can be Robin Hood. That means in some patients, the hospital can charge more, but the poor patients you can reduce. So you have some maneuverability. But if you are pay for use, you have no maneuverability. That much amount has to go to that company every case. That makes a difference. Then what is the most modifiable for you as a surgeon is how experienced you are, how well you have trained the team, and what is the complexity of the pathology you are using. So that will determine the time taken, which I believe, say, in place like Apollo matters a lot, because the longer I operate, the bigger the bill. So what we used as strategy at Apollo Hospital is we defined things into 4. One was reducing the anesthesia time. So when we started actually in 2012, the anesthesia time, people also used to get worried. They would put arterial line, they'll put 5 lines, it took 20 minutes to set the patient up. Today they induce like a laparoscopic surgery. Second is operating room cost, reducing the time of surgery by preparing the patient. So I'm not saying do surgery fast. If the consult time is 2 hours, it is going to be 2 hours. But can we reduce the time other than the consult time, the docking time, the extubation time, the intubation time, so many things. Length of stay. Do AGRS protocol so that you can actually send the patients home very fast. And cost effectiveness in using the robotic instruments. Sorry. So I will just end here. I will open it up for discussion. But before that, I'll tell you something about, because this is my job to tell you guys, there is an Asian Congress going on on 27th and 28th of this month. I know it's a little late. I had circulated this in the group. I hope some of you are attending. This is my first meeting as the president for Asian Society of Gynae Robotic Surgeon. So it will be good to have some of you there. But this is again an agro program going on, and that is there happening in Taipei. But what I would like to invite to all of you is the RoboGynae India 2026. This is our meeting. This belongs to you. I want all of you to come forward, attend this meeting. This has the pre-Congress AGRS Agro Week. But what is more interesting here is 2-3 things. Number one, you all know about Verticuti Scholar, which is the best 5 prizes given for best 5 videos. Then you know AGRS Champions, which is the benign 3 onco best abstracts getting prizes. Third, we have introduced today is a research scholar. So you have AGRS Research Laureate Award for 3 best publications in the last 1 year. I hope the link has reached all of you. Please submit it by the end of this month. Your publication will be addressed. Points are there so that the best publications will get prizes. This year, we are introducing both Saturday and Sunday, 2 hours to 2.5 hours of live surgery, in which we are roping in surgeons from across Asia to demonstrate their surgeries as well as from India. So do attend. We have new things going on in RoboGynae India, including live surgeries, which we were not doing till now. But I thought it was time to introduce that. And that's what we are trying to actually do. This is again coming back to the ASGRS Agro program in India. Please note that the number. You can actually go onto the website and register yourself, or call Michelle on this number and say that you want to register for this. Please do register. This will include the RoboGynae India registration. For all those of you who have already registered for RoboGynae India but want to register for this course, please register. And what you registered for the RoboGynae India, we will refund to you back. So even if you have registered, still want to do this program, please make sure that you register directly on this line so that we have your list there, and we will return back your money, whatever you paid for the RoboGynae India registration. So that's all. I will end here. If there are any more questions, we can take. Otherwise, we will start where do I stop? Yeah. Otherwise, we will start with the panel discussion, and I'm very happy to be part of it if there is anything that I can add.
Thank you so much, Dr. Ruma Sinha. It was a very, very practical and inspiring roadmap that you've shown all of us. And I think I'm sure the bright minds, the new robotic surgeons who have joined this webinar will gain a lot of insight from what you've just told them. And you've clearly laid out that roadmap for them, which is really going to help kickstart their robotic surgical career. I think now with we
So
have an
just
interesting,
one thing,
yes,
Imran. I think Dr.
yes.
Seema will not be able to join due to some personal
Oh,
reasons. So
okay.
we have three: Jyoti, Shraddha,
Sure.
and Maitri.
And Maitri. Okay, perfect.
Please ask them to introduce themselves a little bit about their journey, where they
Yes.
are at the moment, and then
Yes.
start.
Yes, absolutely. Absolutely. So the next part of this webinar is the panel discussion where we are discussing real world problems in robotic surgery, which includes the problems, but not just discussing the problems, hoping to find some solutions from, because the topic is more about the beginning of our journey in robotic surgery. We want to see what problems people experience when they start off with their journey. And we will also gain some insight of how to find some clever solutions from our eminent speakers who've spoken just before this panel discussion. So, Dr. Anshumala, Dr. Rupashri, and Dr. Ruma Sinha, please chip in when you feel the need to, so that we can further enlighten this conversation. So,
Sure. Thanks,
I would
Imran.
love,
I think there are two questions in the chat box also. Maybe at the
yes.
panel, you can just address them as well.
Yes, yes, yes. I mean, I've specifically asked people that if they have any questions to put them in the chat box, and then we can address all of those as well. So, I'd like to welcome our panelists, Dr. Jyoti Raina, Dr. Maitri Parulekar, and Dr. Shraddha Ramchandani. I would request the panelists to introduce themselves and give us an idea as to which part of the robotic career are they in. We would love to hear in brief about your journey individually. So, Dr. Rena, if you can. Dr. Maitri, if you're around, Dr. Shraddha.
Yeah.
Yeah.
Yeah. Hi. This is Dr. Shraddha here. I'm working at the AIG hospitals in Hyderabad. AIG Hospitals, Gachipowli, as a senior consultant in the gynecology. I have started my this robotic surgery since around 8 to 9 months and have completed done around 70 cases so far. So yeah, it's initially we started with the new team means I had to train right from the beginning, right? Training my sisters, then training few technicians were trained with the other departments. But yeah, I have to start from the training to my sisters and the junior consultants in the junior team. So since that initially for about, we can say about 8 to 10 cases, it was like training the people only, our junior staff and all. But now, yeah, it's going on very well because now after these many cases, I know that I have a trained team for the gynecology specifically. So now we are doing even the very complex surgeries like endometriosis and the previous multiple surgeries like that. So we are doing everything now.
That's wonderful. Wonderful to hear. Is Dr. Raina with us? Dr. Jyoti? And Dr. Maitri?
Yeah. A very good morning, Dr. Imran. Can you hear me?
Yeah, I can hear you.
Yeah. A very good morning to all the dignitaries. So just to introduce myself, I'm a consultant MIS and a gynae oncosurgeon. I work primarily from Gleneagles Hospital, Mumbai. And to say I started my robotic journey as a consultant 2 years back. So humbly, it's a new start. And before that, I was trained in advanced laparoscopy and I used to practice laparoscopically. And so it's been 2 years that I've been doing my own robotic surgeries, and it's a gradual learning curve, of course, with the difficult, like grade 4 endometriosis or the onco cases when you go about it. In the beginning, every case teaches you something more, like the fundamentals of using your arm. You have learned a lot about it in your fellowships or training, but when you start applying it, you really need a team and a protocoled approach to go about it. So yeah, looking forward for many more.
Perfect. Delighted to have you, Dr. Maitri. Is Dr. Jyoti Raina there?
Yeah,
Yes.
yes. Yeah, am I audible to everyone?
Yes.
Yeah, very good morning to everyone, and congratulations to all the speakers for this beautiful presentations for all the new beginners. So I am working at Max Dehradun. I'm as an associate director there. I've started this robotic journey from last 2 years, and I've completed my 300 plus cases. And yes, I too have my earlier complications and certain falses in the early beginners, in the early beginning cases. But now with 300 plus cases, I definitely love this innovative tool because it has given a great precision with dexterity, and especially in the difficult cases where endometriosis, multiple surgeries, fibroids, where this technology has really benefited a lot.
Perfect. Thank you so much to all our panelists. I think we'll just start off with the questions. I would like to just start off with an icebreaker, because this forum is for the beginning of a robotic surgical journey. Was there ever a moment when you started off with your first robotic case and you felt, oh my God, this is much harder than I expected? Because I still remember that when I used to train, I would see my professors operate. It always seemed very easy. And when you actually go and sit on the console yourself, you realize that, hang on, it's not as easy as I thought it would be. Would love to know if there was a moment, what you were doing at the time that you realized that it's much harder than you expected. Dr. Maitri, I'll ask you to take that question. Is that okay?
Yes.
Yeah.
Yes, Dr. Imran. So I think initially there were a lot of moments like that because I was trained in South Korea for a year, and whenever I saw my professors and under their mentorship, when I operated, things seemed much more streamlined and easier. But when I came back and I started operating by myself, even applying the simple fundamentals like how to use a third arm effectively and how to create good exposure in grade 4 endometriosis case, or whether or to do an early deployment of the third arm, or should I, thinking about the financial aspect of it, everything seemed a little difficult to tackle by myself. So there was a point when you would have that in your mind, that would it have been better if I took this case up laparoscopically and just finished it off, rather than tackle these small difficulties by yourself. So
That's a very, very fair point. I think we've all been through those sort of experiences and the ups and downs, when in the journey of when we started with robotic surgery. I've just looked through the chat box, and Dr. Smita Joy has asked a question: where to place the assistant port? If I can request Dr. Jyoti Raina to answer that question. Where do you normally place your assistant ports?
Yeah. So initially for the first 5 to 10 cases, as I was using the fourth arm also. So we used to have the assistant port on the right side. So for the assistant to be easily for the suction and the other passage of the needle holders and some specimen retrieval, because that gives an edge. You have a ROGAS on the right side, and you have a bipolar forceps on the left side. So you have a grasping instruments on both the sides. So that is one advantage. But nowadays, because sometimes when we do a docking in the center of the patient, where we don't have to do any vaginal manipulations, I would go for the assistant on the left side. So this is how, if your fourth arm is going to be there, so your assistant placement mostly we put on the right side.
On the opposite side, the assistant port.
Yes, yes.
I think it's also important to note, if you agree, that the OT setup really matters how
Yes,
you do things,
yes.
because in Mumbai the OT space is significantly smaller, so
Mhm.
the robot is quite a huge piece of equipment. So assistant port adjustments can also depend on how your OT is. Would you agree with that?
Yes. Definitely. It depends on the space and where your anesthesia alignment is also there, because you cannot obscure that place also. And for that, if the space is very confined and your console and the patient distance and that
Yeah.
is the alignment is there, and then you have to place your assistant port accordingly.
Yeah. And I think also, to make the assistant port easier, having multiple screens in your operating theater for the assistant
Yes.
is also equally helpful. And let's not forget our person who is in the at the bottom end, where they need to see the
The
screens.
vaginal. Yes,
I think that's very important.
Yes,
That's
that's definitely true.
That's a point very well taken, Dr. Rena. Thank you for that. This is another question from the chat, where Dr. Rajiv Dhal has asked the question: is the docking always done from the left side? Dr. Shraddha, can you shed some insight on this?
Yeah, Dr. Imran, actually at our place we have X system. So yeah, so in that case we always come from the vaginal and we do the central docking only in most of the cases. I think for XI and all you will be having that means freedom to do that. But being
Okay.
for the X surgeon, we are doing from the central docking only.
Central docking, is it?
Yeah.
Okay. But then
I mean
vaginal,
from the
but then
vaginal.
vaginal,
Yeah.
vaginal manipulation, does your assistant find enough space? Because
The vaginal manipulation may be difficult in some times, but we have to have a criteria of a very low BMI assistant at the
right,
vaginal end if we are having the
right,
central docking from the vaginal end. But still,
sure.
we are able to manage because our team, as I'm saying
Yeah,
that now our team is so much trained that we have specified vaginal assistant. 2 people are there, so
right.
one of them is always there, and they are effectively able to do it.
Okay, okay. I
Yeah,
mean, the hospital that I work in, which is Saifi Hospital, also has an X.
yeah,
But we tend to do a side docking with the X.
yeah. Some
You
people do
can
the
do
side.
that as well. And I think Dr. Anshumala very beautifully showed in her presentation as to how we can do a side docking with the X, so as
Yes.
to allow some access for
Yeah.
the assistant to
Yeah,
come
maybe I'll try
in
that
between the
side
legs.
docking now. Yeah.
Yeah, because it really works, and there is
Yeah.
absolutely no difference in the core operating experience.
Yeah.
So I think a side docking is something that we can consider with the X as well. It is a little painful, just like how it was with the SI,
Yeah.
and it's significantly easier with the XI, but it is feasible. So I think that is something that we can look at. And is it fair to say that depending on the OT setup and where you want your graspers arranged, whether you dock from the left or the right side is a surgeon's choice? Is that fair? Would the panelists agree?
Yes.
Yes. It depends, Dr. Imran. It depends on the ergonomics of the OT also, your assistant, your anesthesia team, and what type of patient you're doing. Like if you don't need a vaginal manipulations, where you can do a easily central docking there because you don't have to put anybody at the vaginal end. But in the
Right.
hysterectomies and the
Hello? I think we
like
lost. Yeah,
the cases,
yeah, we
yeah.
lost it there for a moment, Dr. Rena. Yeah.
Yeah. So for the cases where you need a person at the vaginal end, it's very important. For me, as I do the cases, it has to be on the lateral docking. We do the docking on the left side. The assistant sits on the right side, and that becomes little easier for the manipulation. And those cases definitely where you don't need any vaginal manipulations at that time, you can go for a central dock.
Perfect. Another question that I would like to ask is, well, what is the most common intraoperative problem that beginners encounter? And how do you sort of go about handling it? Dr. Maitri, would you like to answer that?
Yes. So in the beginning, I think one of the most important things in the early cases is the use of clutch is
Yeah.
not that frequent, not that much as you should be doing, and then you're just fumbling a lot and wasting a lot of time with repositioning your arms, and your brain is not really wired to keep using the clutch again and again. And I think then you're not using the fullest capability of your robotic system, which should be done. So I think there's a certain learning curve to that. The second thing, what I faced in my early cases was, especially if you're used to operating advanced laparoscopy and then moving on to robotic cases, is creating exposure, and there is kind of an underutilization of the third arm, if you are so to say. For example, your primary monopolar scissors and you're focusing on your bipolar, that is on your mind. But if you're retracting something with a third arm, say progress, you're not frequently changing it, you're not using it in a very dynamic way as you should be using to create an adequate exposure. And then in a difficult case, you're struggling with that. So I think there's a learning curve to that, and I have had one complication, an inadvertent rectal injury, so to say, just because my third arm had a progress when a grade 4 endometriosis, and the POD, it was a frozen pelvis. POD was stuck, and there was a C component, an A component. So I was quite focused in dissecting in the POD, and I kind of, it slipped out of my mind the amount of pressure the progress was inserting in retracting the rectum, and I asked someone to manipulate the uterus to give me better exposure, and it just, there was a small rectal tear inadvertently because of that. So yeah, these are the things I think which beginners fumble with, and you learn with every case in that.
One other thing is that the tactile sensation, if you are used to the laparoscopy for a long time, and when you start in the initial period of the cases, the loss of the tactile sensation is, you feel like a problem. But yeah, with the experience, then the visual clues also you get, and then that can replace, and the very close magnification, all these things compensate for the tactile sensation, I think.
Yeah. I think that's very well put, Dr. Mehri. I share your concerns completely. When you start off with the robotic journey, if you ever see or enter an OT of an experienced robotic surgeon, you will always hear the two, 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 two. And why is that? Is because they're constantly adjusting the clutch and constantly adjusting the camera. And that has a learning curve. And the moment you have that in your armamentarium, where your clutch is under control and your camera is under control, that's where things start becoming a little easier. And very well put about the fourth arm as well, where you can end up with a lot of problems if you don't know the strength of your instruments. I would just like to add one more thing, which is misfire of energy.
Yeah.
That is one thing where people are starting there when they're with their initial curve of robotic surgery. There is a genuine. You should be conscious of what energy pedal you're about to fire. There are fail-safe mechanisms within the place where when you swivel your leg over the sensor of which way you want to fire, that part of the screen
Yeah.
highlights before you fire
Yes,
it actually.
yes.
And I think we need to be cognizant of that very, very carefully. Otherwise, we end up having a regrettable complication. So that was a very, very interesting discussion that we just had. Now, another question that I would like to ask the panelists is, where do you draw the line? Where do you say that no, 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 definitely this patient I'm not going to do robotically? Because I think when doctors will be starting with the journey in robotic surgery, they will be questioning themselves as to which patients should I be posting for robotic, or no, 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 I don't think I'll be able to manage it robotically. I'm sure in your initial robotic surgical journey, that question must be coming to every doctor. So are there certain cases that you can think of where you say robotic is an absolute no-no?
Yeah.
I'm
Can I
happy for
take?
any of the panelists to answer that. It's not a
Yeah.
problem.
See, that was not now, but initially, during my initial cases, what I used to think that if the pathology is too big, means it's going above the umbilicus and multiple fibroids too big, 26, 28 weeks, then I used to think that the robo is going to give me a very narrow vision at a time. Only small place I can expose, and maybe I can do more detailed surgery in a small place, but not in a wide area. That was my initial thinking. I used to be a little afraid of those cases. And other cases where if there is any previous multiple surgeries and if I expect that there will be a lot of adhesions, that won't be able to manage. But now I think that I just need the laparoscopic initial adhesionolysis only to put my ports. But after putting the ports, whatever adhesions are there, yesterday only we did a previous 3 cesarean case hysterectomy. So there were a lot of adhesions up to the umbilicus. But then now I think I have to just expose laparoscopically only the adhesions coming in the way of the ports, but the rest of the adhesions can be very nicely managed with the robo only. But that was in the initial period, that these two scenarios, very large pathologies and multiple adhesions, I used to be a little afraid of.
Okay. I think sorry.
Yeah, so Dr. Imran, Dr. Shraddha rightly said, it's the very large pathologies with the adhesions, with multiple surgeons, where we can acquire a hybrid technique. That means the laparoscopy along with the robotic. Two important things which I encountered in the early cases. One was for the large pathologies, the blood loss. So
I think we've lost your audio again, Dr. Jyoti. Hello?
audible?
Yeah. You're back.
So, second case is the compartment syndrome, which I encountered in first 2-3 cases. So, whenever you start with the journey of robotic, it's very important you get your Allen strips for the patient, because for the longer surgeries where you have multiple adhesions, endometriosis, or the large fibroid uterus, 3 of my patients had a nerve compression, the leg compartment syndrome. And later on, the patient was for a longer time with the physiotherapist. You know, for the corporate sector, sometimes it's very difficult to manage those things and to make the management ready to get those things which you really need for the surgeon, for the surgeries. So this is very important, that the compartment syndrome has one of the issues with the long surgeries. Second, the blood loss that has to be tackled. Early, you have to manage with the large fibers. If you're taking all the pre-op things, your blood, the informed consent for laparotomy or the laparoscopy, if you're converting, that's very important for these cases.
Perfect. I think there's a question from our audience. Dr. Sunita Maurya has mentioned how to remove the specimen after myomectomy. Happy for you to take that?
Yeah. So post myomectomy, definitely. If am I audible?
Yes, you are.
You're audible.
Yeah. So post myomectomy, definitely we remove the specimen from the assistant port through the morcellation, where we want in the young girls, or where the patient doesn't want any larger uterus, where they don't want any scar. So we definitely go for the morcellation, and that is through the assistant port, where we have to extend the port around 10 to 12 mm. That is all.
We've lost your audio again, Dr. Jyoti. I think we can't hear Dr. Jyoti now. Dr. Maitre? Yeah.
Am I audible?
Yes, you're back.
Yeah. So it's very important, because in-bag morcellation is very important, because we don't know the nature of the myomas, and that is through the assistant port we usually do the specimen retrieval.
Okay.
Yeah, sometimes we do it using a wound protector also, taking a small incision, putting the wound protector, and then the
we can
morcellation through that wound, that also can be done.
Yes.
Or otherwise the mechanical morcellator, what we use.
Okay.
Yes.
Yeah.
Perfect. Another question for Dr. Maitre. In case you have a very obese patient or a heavily scarred abdomen or multiple previous surgeries, how does your approach change when you do things robotically?
I think if you personally ask me, for an obese patient, robotic port placement in robotic surgery works much better than a laparoscopic approach because, somehow things become much easier. Of course, the preparation with the head low and the bowel preparation has to be done effectively. But in an obese patient, then I do prefer to deploy one arm for retracting the bowel. Even in robotics, if the financial aspect is not so much of a concern. Apart from that, I think in a heavily scarred abdomen, I don't think there's an issue with the adhesions per se. And in when it comes to robotic, in fact, it helps me more than laparoscopy. What I am more concerned about is placing my ports in a really petite woman with a large pathology, because then placing the ports in a linear placement and having adequate space in between the arms and to avoid clashing of the arms becomes really of an issue. And it's quite tricky in the beginning to place arms in a woman who has a really petite frame. So I would still like the
That's more challenging.
experts to help us in that and how to really place your ports well in a petite frame.
I'll
with large
request
pathology.
Anshumala to shed some
Right.
light on it
Yeah.
because she gave such a brilliant lecture
Yeah.
on the technical setup. Is Anshumala there?
I'm here.
Any
Yeah.
strategies, Anshumala, for putting ports in a very petite patient with a large pathology?
Yeah, I think the first thing is that there putting the fourth arm is going to be very, very difficult. So what I would use is what I have learned in my initial SI times where we didn't have the X or the XI is to do a W. So the W actually is the central camera port, and you have two lateral ports which are 2 fingers below 8 centimeters apart from the central camera. And your other 2 ports, your assistant port and the fourth arm, will come in a W fashion above the camera port. So that W or the invert or an M, you can say, actually works for such a configuration. Otherwise, it's just a curvilinear, but not taking the fourth arm and just doing just with 3 arms. That would work.
That's great advice.
Yeah.
One more teething problem: instruments clashing, and arms clashing. Anshumala, just
Yeah.
couple of words
So
of
see,
advice.
if you kept a fist of your distance between the 2 ports, generally the instruments will not clash. Not with what we have right now. The instruments are much slimmer, better. The camera is better. Your port is not 10 mm, 12 mm. It's an 8 mm there. But here. When you are docking it initially, like I said, the elbow and the shoulder of the arm has to be spread out evenly. You cannot have it too clamped up because then that is going to give you a very little leeway to move your hands correctly. And make sure that the elbow of so especially of the second arm. So when you've got the center camera, and of course, this arm from the right side has got a very long way, it gets stretched out and then gets docked. But the other arm, the third arm, which is on this side, generally tends to get very squashed and close to the camera. So you use the button which is on the arm to move the elbow out. So the elbow should be spread out. So you should basically look at a tulip. That's what I mean, tulip or a lotus. The arms should look in this phase. They should all be phased like a lotus would be, but with a distance of at least, say, a fist between all the arms. So you make sure that you align those. You're making your arms stretched out well enough. They're not buckled up too much too close, and the elbow is not coming and hitting against the camera. So just be careful about that. I think that basically helps. And in the XI, taking a linear incision actually works very, very right, very, very well. So there is really no need to. There are very few arm clashes that are happening with the XI robot.
That's brilliant advice, Anshumala. Thank you so much for that. I have a question for Dr. Ruma Sinha, if Ruma Madam is around. Dr. Ruma?
I'm there.
Yes, Madam, there is always this dilemma. We always tell that when people start with their robotic surgical journey, just to get familiarized with the system, use, probably do an easier case rather than a more complex case. But on the same times, there is this dilemma that the robot is designed to help out with more complex cases. And if we are using a lot more expense for a patient, it needs to add value in terms of the outcome. So a lot of people feel torn apart with that mental dilemma. Is that how do I justify doing a simple hysterectomy, robotically? क्योंकि मैं, she will benefit with endometriosis and onco and this and that. But can you shed some light with your wealth of experience that as to why this is important from a training perspective, and then you move on to the more complex work? I think that's important for the audience to know.
Thanks, Imran. I think this is something which really needs to be addressed. Now, as I said, the training, we are having 2-3 types of surgeons getting onto the robot. Now, for example, I'll tell you about me. 15 years back, when that robot was in front of me, I was a good laparoscopic surgeon. I still am, do still laparoscopy surgery. So let me just put it on everybody. Don't get under pressure that you have a robot, everything needs to be done by robot. The challenge is that if you're a good laparoscopic surgeon, a simple hysterectomy, you'll feel let down that why did I use this and expense more and all those things. Having said that, doing a few simple cases will probably help you, because today is not the same challenge that I had. You have some insurance, patients may get covered. So feel free to do 1 or 2 cases which are simple so that you get used to the robot. However, when you start, and I think everybody like Jyoti, Shraddha, our robots are under pressure for many departments. We have too much work. We can't finish all our work in the robot. Even I struggle. I have priorities, still I struggle, right? So what do? We do responsible deployment of our technology. If you are a good laparoscopic surgeon, you will also get a satisfaction of doing a difficult case. At the end of the day, you'll sleep better. Okay, I made the patient spend more. There was more difficulty in doing, but I did a better case today. So I would still suggest in India, we cannot follow what's happening across the world. We still have limited robot exposure. Number of robots in the hospitals are less. Number of surgeons are more. Utilize your robot where you feel laparoscopy may be difficult. There is a thought about doing, total robotic practice or something like that. It will come, provided more platforms will come. Every theater will have a robot. We'll do everything robotically. Actually, if you ask me an ovarian cyst, I would actually happy doing it robotically, but I don't. Because if I start doing that, when will I do my complex surgeries with robot? So that is one way to take it. But definitely today, with the advantage of having so many robots, so many different platforms, the patients knowing what is robot, they're asking for robot, you have insurance coverage, try doing few simple cases to get a hang. However, your console learning should not happen on the patient. It has to happen before you do the case. So there is no shortcut to the number of hours any beginner should put on the console. Please believe me, if you do that, what Imran was talking, that initial frustration that you said, oh, why am I doing this? Let me finish laparoscopically, will not come. Then you will actually do so efficiently with your robot that you will fall in love and say, oh, why not I do everything like this? So that is my advice to everybody who is beginning. Please do some simple cases so that you get the hang of it. But if you have limited time on the robot, try to take the more difficult ones to robot and still finish your work laparoscopically. So for resident training, I would still recommend all of you as residents, whichever department you are in or whichever hospital you are in, please learn the laparoscopy. At the moment in India, you cannot do without laparoscopy. You have to know laparoscopy. You need to know your hysteroscopy. You need to know the basics, fundamental of minimal access surgery. We are trying to promote you from being good laparoscopic surgeons to an excellent surgeon by using the robotic platform. But you won't reach there till you're a good laparoscopic surgeon. So please remember that. Do that. That's my advice to everybody.
Thank you so much, madam. Madam, one last question. How many proctored cases do you recommend before you go solo? In your opinion, how many proctored cases?
Okay, so again, it depends upon 2 things. One, you don't really need too much proctorship to run your console if you have practiced well. So no proctor will come and say, ye clutch dabao ya ye haath lagao. That you have to learn. If you think you need domain knowledge, that means how to do a stage 4 endometriosis, and you have, say, good experience of doing laparoscopically, maybe 2 cases may be sufficient, 2 or 3. But if you have never done stage 4 laparoscopy for robotics, for endometriosis, then you may require 5 or 6, because then you need to have 5 or 6 domain knowledge. Ureterolysis kaise karna hai, how to make sure that your ureter at the Mac-and-Rod ligaments is safe, how to do bowel reach the medial, pararectal spaces, how do you do your hysterectomy, bladder dissection in a previous cesarean section cases. So identify, if you are the beginner, identify 5 areas which you are having difficulty, or if you think you may have difficulty. Get your proctor to help you in those cases, which can be now online as well. I think this hub is coming in. There are other technologies now, which we can say, I can sit in Hyderabad and get onto your live surgery for 10 minutes and tell you, okay, yeah, this is your bladder dissection, go into that lateral space, do this, do that, and you will be able to do it. I need not be there physically in your theater. We are working on that. Hopefully, technologies will help us. I'm hoping we will get more hubs in India. There is another technology which is coming up, which gets hooked onto a robot. We'll see if we can deploy that. But we are trying to, if all of you are, actually, I want all of you to, whoever has attended, most of you are our members, put back in the WhatsApp chat 2 things. One, do you think online surgical coaching do you need? So we can then, select some surgical coaches for you who will be there for 6 months in your journey. And you can, call them up, tomorrow I have this case, how do I approach? Or during surgery, can you be there for 10 minutes with me? That way. The second is, do you want these seminars to happen more often? We have not been able to do it, but now with Imran and Anupma on the helm, I'm sure they will put up the programs very fast. We have a RoboGyne India towards the end of August. We can do one more webinar in July if you want. Pick up some topic, because this is just all of us sitting at home and giving us some time. If you want more often, please put it in that box, and we will try and address that to all of you.
Thank you so much, madam. I think we've run over time because this discussion was so, no. I think we were meant to do it till 10:30, and it's now 10:45. But it was such a stimulating discussion, and I'm sure it was immensely helpful to everyone in the audience as well. There was one question from Dr. Al, saying that I dock from the right side. Does that matter or not? I think we've answered that question with our previous discussion. So I'm just going to close, give my closing remarks, for the webinar, saying that the 3 things that I've taken away from Dr. Anshumala's lecture was a meticulous setup is incredibly important. Dr. Rupashri Dasgupta was able to demonstrate that the indications for robotic surgery are ever expanding, and of course, Dr. Ruma Sinha, Madam's lecture clearly showed that training is a journey and not a destination. So, with that, I really want to thank all our speakers, Dr. Anshumala, Dr. Rupashri, Dr. Ruma Sinha, and to our panelists as well, Dr. Raina, Dr. Parulekar, Dr. Ramchandani, for giving their valuable time on a Sunday morning and enlightening our audience with the journey, how to start off and take on the journey of robotic surgery. Appreciate everyone being here. Any last words from our panelists and the speakers is most welcome.
Yeah, Dr. Rupashri, you want to say something?
I just want to invite everybody today on this platform. You can come into the AGRS website as we have shared it. And the more number of people we have on board, the better we can all work as a community, learn from each other. So just click on to agrs-india.com, go to the membership portal, take a 1-year or 5-year membership. If you still don't have a robotic certificate, once you are certified, you can take the lifelong membership. And I thank Dr. Imran, Dr. Anupama for giving this opportunity today and this wonderful discussion that we had today, and of course respect to our madam Dr. Ruma Sinha, and regards. Thank you so much.
Anshu, last word.
I think the last word here is for what I have seen people struggling with them when you're beginning your robotic journey. One is that you make sure you get a very sound training in basics, because you can't just sit on the console and then suddenly find your hand going in different places and not understanding and forgetting to move the camera. It's the most common thing I see, that you're operating somewhere, but you just don't have the insight to know that you are the one who has to move the camera. So I think you have to take it stepwise. It can't be a short journey where you suddenly learn something. You have to learn the equipment first. You understand how you're going to do it. The perspective is different, where a lot of control is in your hand. And always find a good mentor who can help you at any point of time. I think that just, even a single call sometimes just before you start a case, if you have a good mentor who's there who can help you, it makes a very big difference.
I think we can, Imran, you can help us, and somebody can, work on this to design a program as a surgical coach. Many of us are now capable of doing that.
Yeah.
We can, take 1 or 2 under our tutelage and 6 months help them out, and so that they are on the job. So I just want to end this with one important point. Number 1, AGRS is your society, your platform. Please feel proud to be part of it. At the moment, we have more than 350 members, which is amazing because we are only gynecologists. Remember, most other societies have many departments together. So 350 gynecologists on a robotic surgery platform is great. But Rupashri is working very hard to increase that number, and I trust her. Number 2, today with this program, we have close to 140, 145 people who have already registered. That shows how many of... Huh?
Ma'am, 188.
188, low. No, the latest number is 188. So we have close to 200 people getting on a Sunday morning to learn. Imran, we need to do one in July as well, right? So this is your platform. Please feel free, send your best work. See, you have to understand the program that we are trying to do in RoboGyne India is a very dedicated program, single hall. I know most of you want to be part of it, and I want you to be part of it. But send your best work so that we know what you're doing and give you an adequate time to present your work so that you get the visibility. We may not be able to have everybody on a faculty list, so-called, as you expect, but believe me, we are just trying to turn the tides, make it more inclusive for everybody, making sure the delegates who come feel that their time was well utilized, they learned a lot and went from mentors. That's a little different approach I'm trying to have as compared to many other conferences that go on everywhere. So this is my sincere request. Consider AGRS as your own. Become members, contribute, give us ideas what you want to do, make more friends of yours, become members, and let's work together. Thank you.
Thank you.
Thank you.
Thank you very much, everyone.
Thank you. Thank you so much.
everyone. Thank you
Hi
so
guys,
much.
it was good. Thank you, Imran and
Yeah.
Anupma, for putting this together.
Thank you.
Thank you.
Thanks, Anupma. Thanks, Imran. Bye-bye.
Thank
Bye.
you.
Thank
Anupama.
you. Thank you so much.
Thank
Thank
you,
you,
ma'am.
everyone.
Thank you. Thank you, sir.